Hello, my name is Dr. Mei Tuong, and I'm an assistant professor in the Department of Urology at the University of Virginia Health System. My specialty focuses on restoring function to the urinary tract, reconstructive urology, and cancer survivorship. Thank you for joining me for this September's prostate cancer awareness talk on urinary function recovery after prostate cancer, specifically stress urinary incontinence. Urination can significantly be altered by both radiation and surgical treatments and can negatively impact your quality of life. One urinary problem that can develop is stress urinary incontinence. Stress urinary incontinence is unwanted urinary leakage with movement, sneezing, coughing, laughing, and lifting heavy objects. This can occur in up to 25% of patients treated with prostatectomy and 11% of patients treated with radiation. Type of surgery or radiation do not impact the severity of stress urinary incontinence. And at 15 years after treatment, the number of patients experiencing stress urinary incontinence are the same between the two treatment therapies. In general, surgery can cause immediate stress urinary incontinence, while radiation leads to a slow development of stress urinary incontinence. Stress urinary incontinence can also take the form of leakage of urine during sexual arousal or during ejaculation. After radical prostatectomy, 70 to 90% of men will regain the ability to stay dry at 6 months. Some men will continue to see improvement in their urinary leakage up to 12 months after surgery. After 12 months, though, the level of stress urinary incontinence is unlikely to improve. One of the major tools to prevent and lessen the severity of stress urinary incontinence after surgery is to schedule a consultation with a trained pelvic floor physical therapist prior to prostatectomy. The pelvic floor muscles, as shown in the picture, support the bladder and the urethra and are crucial for bladder and bowel control, sexual function, and overall core stability. These physical therapists are often different than those who help with orthopedic and back injuries. Former pelvic floor muscle training programs help you learn the function of a pelvic floor muscle and how to use these muscles in keeping you dry after surgery. This has been shown to help, especially if these exercises are started at least 3 weeks prior to surgery. You can find a local men's pelvic floor physical therapist online or on the American Physical Therapy Association website. After surgery, you should start pelvic floor muscle exercises as soon as the catheter is removed, as long as you are cleared by your surgeon. This has been research proven to help you regain urinary control quicker than those who do not. This may be as early as 3 months after surgery. Disposable absorbent products such as diapers, pads, or thin liners are commonly used to manage leakage. Reusable absorbent underwear can also have success. Catheters such as indwelling Foley catheters, suprapubic tubes, or external urinary catheter, like a condom catheter seen here, are options in select patients. Penile clamps are an external device that keeps the urethra shut for small extended periods, preventing leakage of urine. New incontinence after prostate cancer treatment may not be stress urinary incontinence and instead could be leakage from an overactive bladder. This is treated very differently and will be discussed in the video by my colleague, Dr. Zillioux. For patients to mild to moderate urinary incontinence or less than 5 pads a day, the male urethral sling is a great surgical treatment. There is no device manipulation needed by the patient after placement. The sling works by repositioning and supporting the urethra after sling placement. 62% of patients end up using 0 to 1 pad a day after placement of the sling. Unfortunately, this is not a good option for patients treated with radiation. The surgery itself is minimally invasive and is an outpatient surgery, which means you go home the same day. Risks include needing a second surgery for incontinence after 5 years, new growing pain from sling placement, and rare urinary retention. An artificial urinary sphincter is a mechanical device used to treat all levels of incontinence and is the recommended surgical treatment in patients with a history of radiation. This is a three-piece mechanical device where an occlusive cuff is placed around the urethra, keeping the urethra closed constantly. In order to urinate, you squeeze a pump located in your scrotum, which opens the cuff and allows for urination. This is the surgical treatment with the highest success rate. 20% of patients are completely dry, 55% will leak a few drops, and 22% will have less than 1 teaspoon of urinary leakage a day. Similar to the sling procedure, this surgery is an outpatient surgery. In order to work this device, the patient must have good hand dexterity and no history of dementia. Risks of the surgery include mechanical failure of the device, erosion of the cuff into the urethra, and device infection. Lastly, these devices need replacement after 8 to 10 years. Adjustable balloon devices are a minimally invasive surgical procedure that places implantable fluid-filled balloons against the urethra and the bladder neck, as seen here. The balloons support the bladder and apply pressure to keep the bladder opening closed. Candidates for this device are non-radiated patients with mild to severe incontinence. The amount of fluid within the balloons is adjustable and can be done in the office, allowing for tailoring of the device to a patient-specific incontinence goal. There's no patient manipulation of this device. Risks of this procedure include urethral or bladder perforation and a higher rate of device removal compared to the artificial urinary sphincter. Thank you for listening to this presentation on recovery of urinary function after prostate cancer treatment, specifically regarding stress urinary incontinence. On the slide is my name, contact information, and clinic phone number to schedule a consultation with us here at UVA Urology. I'd be happy to meet and talk with you regarding any of your urinary or sexual concerns after prostate cancer treatment. My hope is to give you back the ability to live your life after cancer. Thank you.
Hello, I'm Dr. Jacqueline Zillioux. I'm a urologist here at the University of Virginia, and I'd like to speak with you about urinary function recovery after prostate cancer, focusing on overactive bladder and urinary urgency incontinence. So what is overactive bladder? It is a group of symptoms that can include urinary urgency, frequent urination during the day and or nighttime, with or without urinary incontinence. So that is trying to get to the bathroom and not quite making it in time. There are two different common types of urinary incontinence or urinary symptoms that need to be differentiated. So the first is stress incontinence, which Dr. Tong was talking about. That gets a lot of the attention with regards to prostate cancer. That's the type of leaking that you have with exercise, coughing, sneezing, laughing, lifting something heavy. Whereas what I'm focusing on here is overactive bladder or urgency urinary incontinence, and that's that gotta go, can't make it in time, can't hold it in because that urge to go is so strong. Many patients might have overactive bladder symptoms present before they have their prostate cancer treated, and that's because this can be common in men in general and is commonly related to the prostate itself. You may know a lot of men, or you may yourself have been getting up a lot at night, having new urgency and frequency as the prostate's gotten larger, or it's been attributed to an enlarged prostate. There are some cases where prostate cancer could be causing a blockage of the outlet of the bladder, which puts stress on the bladder, and a stressed out bladder has more urgency, more frequency, because it's not emptying as well, and it's stressed out from having to squeeze so hard to try to get the urine out. At the same time, overactive bladder is common and a new symptom after prostate cancer treatment. And a lot of the focus is usually on leaking with coughing, sneezing, laughing, that stress incontinence. But it does seem that overactive bladder is common as well. Estimates range from 6 to over 50% of patients having this after treatment, and that includes radiation and surgery. Oftentimes, the urgency in overactive bladder gets better with time after treatment by 6 months, but for a lot of patients, it still is persistent. Now, thankfully, there are a lot of treatments available for overactive bladder. This is a slide from one of our national organizations' guideline on treatment for overactive bladder, and these guidelines are meant for all comers, not specific to prostate cancer patients, but we still apply the same principles. And as you can see, this is sort of a menu of options that are based on shared decision making between the patient and the doctor or provider. And traditionally, the treatment options were very linear and hierarchical. You had to do non-invasive, non-medications first, and then medications, and then go on to more advanced therapies. But with these 2024 updated guidelines, we as a specialty are trying to shift the focus from that linear hierarchy to having a menu of options that's based on the patient themselves and the patient situation. Now, insurance companies might not always be up to speed on this, but this is what the goal is. And so generally, as a foundation of treatment, you look at those non-invasive therapies. These tend to be lifestyle options. A lot of these also help with stress urinary incontinence, as Dr. Tong might have talked about. These options include pelvic floor physical therapy, timed voiding or going on pee on a schedule to try to stay ahead of that urgency every several hours during the daytime, and avoiding bladder irritants like coffee and caffeine and alcohol. Now, when those non-invasive therapies aren't helping, we have medication options as well. And these are called pharmacologic therapies, and there are a bunch of different medications. One of the common types of medication, and this is the oldest class of medications, are called anticholinergic medications. And these anticholinergics help with overactive bladder by blocking those squeeze and urgency receptors in the bladder. But they also have a lot of off-target actions elsewhere in the body and can cause many side effects such as dry eyes, dry mouth, and constipation. You'll see here that there's a little brain marker here as well. And there's some concern that anticholinergic medications might cause an increased risk of dementia or memory problems later on. This really hit the news in 2019 when there were a couple big studies that were published on this topic, seeing headlines in the New York Times highlighting that medications for bladder issues might cause dementia, as well as in USA Today. And should you be worried, and trying to raise awareness about this topic? So the answer is that they might, and they do. There are many studies that show that there's an association. Those studies aren't showing that it's causing it, but it seems to be that patients who have taken certain anticholinergic medications, including ones that treat the bladder, have a 1 to 5% increased risk of having dementia later on in life. That's up to 10 to 15 years later. The highest risk for these we see with oxybutynin and tolterodine, but there are other medications in this class of drugs that do not accumulate in the brain and are probably safe, and I've listed those here. Now, there's a newer type of medication for overactive bladder called beta-3 agonists. These include mirabegron and vibegron that work in a totally different way and should not have these risks with memory. And so if you're thinking about trying a medication for overactive bladder or urgency urinary incontinence, it's important to keep these risks in mind and talk to talk to your provider about these to help find one that's going to be safest for the brain. All right, so that's medications. There are also some minimally invasive therapies that are available as well. These used to be called advanced therapies or third line therapies, and now we just call them minimally invasive. And I'm going to go through these fairly quickly just to give a big picture overview of how many options there are. So the first is called percutaneous tibial nerve stimulation. This involves a small needle placed in the ankle. It's about the size of an acupuncture needle that is used to stimulate a nerve called the posterior tibial nerve that sends signals up to the bladder to calm it down. These involve office visits for 30-minute stimulation, and they are weekly for 12 weeks, and then 9 monthly visits after that to maintain the benefit. So typically the treatment is a year, and it may or may not wear off, but Medicare tends to cover 1 year of treatment every 3 years. Success rates are in the 60 to 70% range. And again, I put an asterisk here because a lot of the information we have about how likely things are to be successful are from studies that are just in a general patient population and might not be specific to cancer survivors. The pros of this therapy are that it's low or no risk, so you might have a little bit of pain at the site, a little bit of bruising risk, but otherwise it's very, very low risk. But the con is that it's time consuming. It's a lot of trips to the office. There's also an implantable version of this therapy that's newer, available just over the past couple years, and there's a couple different options. One is a coin-shaped battery called the eCoin that shown here that is placed in the similar area where the needle is placed. There's also another version that is that little rod type implant that's placed, and then you wear an ankle bracelet to deliver the stimulation. These therapies have 70% or more success for urgency urinary incontinence. Again, not a cancer population, but just kind of non-cancer patients where this was studied in. The pros of this is that it's much more convenient than the PTNS and can be delivered more frequently. The cons are that it's a permanent implant, it's costly, and has very spotty insurance coverage. But for those that do have the coverage, it can be a nice option. Many times for my patients, I suggest trying the PTNS first to see if you're a responder to the therapy before going on to having the implant, just because it's a very low risk procedure to place it, but it's very costly, and it's nice to know if it's something that might help, because there are a chunk of folks who don't respond to the therapy, unfortunately. Another advanced or minimally invasive therapy is sacral neuromodulation, and this I like to call a bladder pacemaker. It looks like a pacemaker, but it doesn't actually work exactly like it. But it involves putting a electrode lead through the sacral 3 foramen in the lower back to help stimulate the nerve that helps control the brain talking to the bladder, and vice versa. It delivers a low-level continuous stimulation to that nerve to calm it down, and it just happens in the background without you needing to really do anything. This is a therapy that you have to try before you buy. Insurance companies require a test phase where either in the office or in the OR, the wire or the electrode is placed. You keep a diary before and after of your symptoms, and if there's a 50% or greater improvement in the symptoms, then that qualifies you for the implant. This also has pretty high success rates in non-cancer populations. It hasn't been studied specifically in prostate cancer survivors, but works very well for many patients with overactive bladder and urgency incontinence. The battery, there's 2 different companies that make this device. The batteries last 10 to 15 years or more. It's overall low risk. The main thing is some rigmarole with getting it, to seeing if it works for you. And then sometimes it's like, I liken it to like having a car. It needs some maintenance. Sometimes it has to have a little adjustment. Sometimes you have to have the battery kind of pocket reconfigured, or have the lead adjusted, or a new lead placed. If the device gets infected, which happens about 1% of the time, it does have to be removed, and that's the main downside. Right. Finally, for another advanced therapy we have is bladder Botox. This is an office-based procedure where Botox is injected into the bladder through a camera. So we fill the bladder up with some numbing medicine, let it sit for a few minutes, and then go in with the camera using a small needle to inject the medicine into the bladder. The medicine takes a few days to start kicking in, but what it does is it blocks bladder spasms and bladder overactivity. And it lasts on average about 6 months, so folks who do well with it tend to get it injected a couple times a year. The pros of this is that it's a quick office procedure compared to sacral neuromodulation. The implant's less rigmarole. The cons are that there's a risk of urinary tract infection, and for men, there's a higher risk of urinary retention, meaning you can't pee, you'd have to either learn how to catheterize yourself or need a catheter. And these numbers aren't necessarily from patients that have had their prostate removed or prostate cancer treated, but we do know that it tends to be higher in men. And I tell my male patients that are considering Botox that it is at least 10% risk, and depending on their situation, and I'll quote it higher. So if we know that the prostate is blocking things off a little bit, the prostate hasn't been removed, or there's some scar tissue or something like that, there's a much higher risk of needing to temporarily use a catheter, and that's because the Botox works by weakening the bladder and blocking those spasms. All right, so take-home points are that overactive bladder and urgency urinary incontinence are common after prostate cancer treatment, but thankfully there are a lot of treatments, and it really comes down to shared decision-making between you and your urologist about what might be the best fit. If those basic things like pelvic floor physical therapy and exercises and medications aren't doing the trick, then you can also ask about a referral to a specialist in functional urology like myself or Dr. Tong, who can talk in more detail about the neuromodulator implant, bladder Botox, or PTNS. So thank you, and this is me. Here's my office number. Thank you for your attention, and take care.